Alrighty. If you missed these QR codes, I'll send out the slideshow after this, and then also I'll have the attendance form again at the end for you. For this exam, your professor has posted narrated PowerPoints. I definitely recommend reviewing these, especially if listening to someone is something that helps you learn. There are also, like I just briefly looked over them, a lot of really good practice questions in your slideshows, especially like the one that comes to mind is like matching questions with the dyslipidemia drugs. Like those are super helpful to just, check your understanding. For medications, again, now you've kind of gotten the hang of what PathoPharm looks like. But when there's a lot of medications and they're super stressful, don't try to study every single medication. Try to study the classes in groups, and it'll help you just study a little bit more effectively. As always, break up your studying. We're basically a week out, so the fact that you're even here tonight is awesome because you're starting to do the things that you need to do to get you prepared for the exam. And this is your last unit exam, guys. Like, genuinely, we're down to like what, 3 weeks left? I graduate in like 22 days or something like that. It's like we're so close to the end. Let's go ahead and get started with dyslipidemia pathophys. Dyslipidemia is just abnormal cholesterol. Even before nursing school, people talk about high cholesterol all the time. I'm sure maybe some of you have heard your parents talking about maybe they have high cholesterol, because it is pretty common, especially in our society with our like common diets. Dyslipidemia is a major risk factor for atherosclerosis, which we'll talk about in a second. And it can be classified into primary and secondary. Primary is just when you have elevated cholesterol that just develops independent of your lifestyle, of your health problems, and often has a genetic base for it. My primary care provider has high cholesterol, and he's one of the healthiest men I've ever like interacted with in my entire life, and he just tells me it's genetic. So that's primary dyslipidemia. Secondary dyslipidemia then would be elevated cholesterol that's associated with disease, health problems, or lifestyle. So think things like diet, obesity, smoking, etc. Atherosclerosis versus arteriosclerosis. This is an important differentiation to understand for your knowledge and also for patient education purposes. Atherosclerosis is the buildup of fat, which forms a plaque in the arteries. And when you get so much of that fat and plaque inside of that lumen, it's going to cause narrowed arteries, so less space for blood to move, meaning less space for oxygen to move as well. It is a leading cause of cardiac diseases and associated deaths, and it can turn into coronary artery disease when this atherosclerosis is in those coronary or cardiac arteries. Arteriosclerosis then isn't the plaque that builds up, but it's the thickening and hardening of those arterial walls, which results in a loss of elasticity, which is required oftentimes for blood pressure compensation. Risk factors here are renal disease, hypertension, hyperlipidemia, inactivity, obesity, smoking, etc. And again, just identifying those modifiable and non-modifiable risk factors, think way back to that first unit. They're pretty straightforward, just things you can change and things you can't change. Modifiable would be nicotine, smoking, diabetes, specifically type 2, hypertension, hyperlipidemia, your lifestyle. But things like atherosclerosis and arteriosclerosis you have a higher risk for them with age and sometimes with genetics. So those are things that you can't necessarily change. Atherosclerotic lesions or atheroma, there's kind of like a formation process here, and I don't want to spend too much time on this slide, but the atherosclerotic lesion begins with an injury to that vessel lining, often caused by smoking, chronic hypertension, or the existence of high cholesterol. That vessel injury will result in inflammation, and then all of your, white blood cells that you've learned about in the past, like macrophages, are going to rush to the area and just kind of start doing their thing. And as we know, inflammation is a helpful mechanism, but a lot of the times, there are some less desirable side effects from inflammation, and we can see that in these processes because they do cause fibrin scar tissue formation, which then further narrows that artery. And again, sometimes, your artery, if this is occurring in a coronary artery, you're going to be at an increased risk for a heart attack or cerebral arteries and stroke. So yeah, This will cause ischemia, which is lack of blood flow and oxygen to a certain area, which makes sense again, because these would be narrowing or temporarily clogging those arterial vessels. Intermittent claudication is caused by inadequate blood flow that results from atherosclerosis. So again, you have your vessel, it's getting smaller and smaller as that plaque builds up, and now you have less blood going to, say, your left arm than is ideal. And that can cause a muscular, crampy-like pain that worsens with activity and improves with rest. These are just your lab values that you need to know. Definitely memorize these. Flashcards is a great way to do that. Your total cholesterol needs to be less than 200. Your LDL is your bad cholesterol, so you want to keep it under 130. HDL is your good cholesterol, so it's actually protective, and you want to keep it above 40 to 50. That's a good piece of education too, because a lot of patients assume all cholesterol is just bad. And that's certainly not the case. We just don't want it to get too high. And again, in HDL, you do want to see higher numbers. And then triglycerides is less than 150. A lot of the time for dyslipidemia, we're going to start with non-pharmacological management. So you can do dietary modifications. You can teach your patients to limit their caloric intake, saturated fat, direct cholesterol, and also just monitoring their weight. And then as well as lifestyle modifications like smoking cessation or lessening, and then working in a little bit more exercise as well. Alrighty, which of the following is a non-modifiable risk factor for atherosclerosis? Perfect. Yep, increasing age. Your patient does not understand how high cholesterol is causing them pain. What education do you need to provide? If you just want to put like a few words or a sentence or two in the chat for your thoughts on this one. Some people are messaging me privately. Those responses look good, guys. Everyone's messaging me privately for this one. That's funny. Um, Yeah. Again, so high cholesterol can cause that atherosclerosis, which can cause impaired blood flow to certain areas, causing intermittent claudication. So you can just kind of explain that it can impede blood flow to certain areas, which can cause that pain. And with intermittent claudication, it's that like wave-like crampy pain. But good job, guys. Which of the following statements are true about intermittent claudication? This is a select all that apply, sorry. Awesome. Yep, that one is going to be B, D, and E. Good job. Which of the following values is outside of the ideal range? Again, this is just testing how well you know those ranges, which I know we're still a week out from the exam, so some of these might be a little bit harder to answer. Yep, that's going to be triglycerides. The goal is to keep those under 150. So it's elevated, nothing crazy, but there is some elevation there. Perfect. So that'll bring us to the dyslipidemia or cholesterol monitoring medications. We've got 5 here that we're going to talk about. The first one, and probably the most common one that you're going to see prescribed in practice, is atorvastatin or your statins. These are often, again, first-line drugs for cholesterol control, and they work by inhibiting an enzyme in the liver that's required for the creation of cholesterol. In general, the statins are usually well tolerated, but they can cause muscle syndromes or myopathies, as well as liver disease, so hepatotoxic. And we'll talk more about those muscular impacts in a moment. In general, though, with statins, you're going to educate them to avoid grapefruit. That's going way back with those CYP4 something enzymes. It'll just make their medication kind of more potent. You'll teach them to take it at night to avoid subsequent use of alcohol. Sorry, my dad is calling me. And then you're going to teach them to stop the medication and to notify the provider if they start experiencing muscular pain, weakness, or darker urine. And that's because an adverse effect of statins is going to be muscular breakdown and further progression. Um, you can just have myalgia, which is just the generalized kind of muscle pain and weakness, which can then progress to myositis, which is actual inflammation of your muscle tissue, which can then progress to rhabdomyolysis. And this is the life-threatening stage of this kind of myopathy. It's a serious syndrome that leads to the death of your muscle tissue, which then releases that muscular content into your bloodstream. The two things that we're looking at is going to be myoglobin and CK. So if you see myoglobin or CK in elevated levels, then you know you're looking at muscle fiber damage. Again, these being elevated will cause that dark urine, which is why you want to educate your patient to report dark urine, because there's a possibility that they're experiencing myositis or rhabdo. Cholestyramine is a bile acid sequestrant. This medication works by binding to bile acid and excreting it through the stool. The really good thing about this medication is that because it's not absorbed systemically, all of the adverse effects are going to be primarily reduced to the GI tract, which is oftentimes constipation. Um, the kind of downside, though, is that they're not necessarily the most effective if given by themselves. So because of that, they're oftentimes used alongside a statin, like a atorvastatin. You're going to supplement with those fat-soluble vitamins A, D, E, and K. You're going to teach your patient to consume high-fiber foods. That's kind of just combating that risk of constipation. And then also you're going to teach them to not take other medications about 1 hour before and up to 6 hours afterwards as well. Fenofibrate is most effective in the reduction of triglycerides explicitly. So if we want to see the most reduction there, fenofibrate is a good option because it works by decreasing the actual production of triglycerides by the liver. It is hepatotoxic and there is an increased risk for myopathy. Again, that kind of muscle damage sequence that we talked about with the statins. And there are contraindications as well for patients who are in liver and kidney failure. And also, if a patient's on warfarin, they can still receive fenofibrate, but you're just going to kind of monitor their bleeding risk and those INR levels as well. Ezetimibe is a medication that blocks the absorption of cholesterol throughout the intestines. Adverse effects here again, you could have hepatitis, so inflammation of the liver, and myopathies, those muscle syndromes. So you're noticing a pattern here. We're talking a lot about the liver and we're talking a lot about muscular damage essentially with these medications. For ezetimibe, it is not to be given at the same time as a bile sequestrant or a fenofibrate. You'll teach them to avoid alcohol. And with the ezetimibe, you should expect to see lab changes in about 2 weeks. So it is a pretty, fast turnaround there. The last one is niacin. It works by inhibiting the kind of movement of free fatty acids. And it's the most effective to actually increase your HDL or increase that good protective cholesterol. Adverse effects can be pretty extensive facial flushing, which is kind of a unique one. Gastric irritation, high blood sugar, liver toxic again. The unique one to remember for niacin is that facial flushing that can come with warmth and tingling, because you can teach your patients to, or you can do it if you're administering medications, to take aspirin about 30 minutes before the niacin administration, or ibuprofen 60 minutes before. Taking one of those two NSAIDs can help seriously reduce that facial flushing, warmth, and tingling. And I know it's kind of like a weird thing, but that's something you definitely should know going into this exam. And again, you're just teaching your patient to report signs of liver toxicity like jaundice, that yellowing of the skin and sclera, nausea, vomiting, and anorexia. Which of the following signs and symptoms need to be reported to the provider for a patient taking atorvastatin? Select all that apply. Text my dad back and see if he needed me. No, we're good. Yep. A, B, and C. Those are all going to be signs of that, the myopathies, that muscular breakdown with the myoglobin and the CK in the urine. Awesome. Good job. Which of the following medications has minimal systemic absorption or side effects? Yep, that one's going to be cholestyramine. That's the one that works by excreting that cholesterol through your stool. So it's pretty limited to the GI system. True or false, you can take aspirin or ibuprofen before taking niacin to reduce facial flushing. That one's true. Your patient is beginning atorvastatin for elevated cholesterol. Which teachings should you reinforce or provide? Select all that apply. I had a few come in privately again. You guys are right, the ones who sent it in. Awesome, guys. Yep. A and B. For C, we primarily take this medication at night. And for D, you want to educate them that that is not expected and that is concerning. So to be on the lookout for that. Awesome. That is all the content I have on dyslipidemia and those dyslipidemia medications. If at any point you guys have questions or want me to revisit any of that content, feel free to go ahead and mention that as well. Hypertension. Hypertension, it's everywhere. It literally will never go away. And even just in adult one clinical for you guys, I'm sure, if you're on med surg or wherever you are, I would bet at least half of your patients are hypertensive. It's so, so, so common in our population. And you are going to see it everywhere in basically every patient population. In general, when your blood vessels constrict, that's going to increase your blood pressure. And when they dilate, it's going to decrease. Um, like if you think about that pathophysiologically, it makes sense. But if you can't remember, think D, the two Ds, dilation, decrease, and then you can figure out constriction is increase. Blood pressure is regulated by seems like 1,000,010 different things. You've got the sympathetic nervous system, which is responsible often for increasing blood pressure. It's that responsible for kind of fight or flight. Baroreceptor feedback, that's just pressure regulators within your vessels. You have chemical mediators, things like histamine and bradykinins can dilate your vessels or decrease blood pressure. Serotonin can increase your blood pressure, and prostaglandins, depending on the situation, can either dilate or constrict those vessels. The big kind of cascade system is that hormonal control RAAS, renin-angiotensin-aldosterone syndrome. And this one you learned about, I want to say, in anatomy before. And it's super intimidating at first, but if you take a moment to just kind of write it out, use your arrows and kind of like a flow sheet, it kind of makes sense, just a step-by-step process. Essentially, when you have low blood pressure, your body's going to release renin. I'm pretty sure it's the kidneys that are responsible for releasing renin. The renin then will convert your angiotensinogen into angiotensin 1. When that angiotensin 1 reaches your lungs, the ACE enzyme or angiotensin converting enzyme, which makes sense, brings that to angiotensin 2. And that signals for the release of aldosterone, which is responsible for, it's a hormone responsible for the increase in blood pressure. So just reading that, I'm sure that doesn't make any sense, but just sit with it, take time, write it out step by step, and you'll have a better understanding of that sequence of events. Hypertension, just like dyslipidemia, can be categorized into primary and secondary forms. Primary hypertension is up to 95% of hypertensive patients. It's hypertension without a diagnosable cause. So these are things like lifestyle choices, your genetics, obesity, alcohol, a sedentary lifestyle, etc. And diagnostics typically require a systolic of 130 or higher and a diastolic of 80 or higher on multiple occasions. It can't just be one time. Secondary hypertension, though, is less common, 5 to 10% of the time, and it's hypertension from a diagnosable cause like renal disease, preeclampsia. You guys haven't taken maternal yet, but you'll talk about that a lot. That's basically high blood pressure with pregnancy, and certain drug side effects. Hypertension can be labeled into just different kinds of classes. Um, you can have a hypertensive crisis, urgency, or emergency. So a crisis, you're looking at a blood pressure with a systolic over 180 or a diastolic over 120. If a patient is in hypertensive urgency, they have super high blood pressure, but they're stable. They don't have targeted organ damage. Um, and oftentimes non-adherence is the most common cause. So maybe they're just not taking their antihypertensives like they should. And then a hypertensive emergency is the worst. It's when a patient is unstable because of their hypertension and there is organ damage involved. Hypertension isn't just, oh, I have high blood pressure, that sucks. Hypertension is a major, major risk factor for things like stroke, heart attacks, heart failure, diabetes, renal disease, and just so much more. Like, there's so much that hypertension can do to your body, and that's why it's really important that we teach our patients how to prevent it and how to lessen it if they already have it. Orthostatic hypotension then is hypotension or low blood pressure caused by a position change. And to be diagnosed, you need to see a drop of 20 or more in systolic pressure and 10 or more in diastolic pressure. Um, it's most common in your older adult populations, patients who have a history of falls, and a huge, huge one is your patients who are on antihypertensive meds, and we'll talk about that more. Also, being dehydrated can increase your risk for OH as well. Clinical manifestations, weakness, nausea, dizziness, blurred vision, and fainting upon standing up. I don't know, maybe someone in here has POTS, or even most people, especially young women, I'm sure you've experienced you stand up a little bit too fast and you have to grab onto something because you get dizzy and your vision blurs. That's what it feels like when you have orthostatic hypotension. It's just that poor compensation of your body with position change. And instead of your blood pressure, staying high enough to support yourself when you're vertical, it just doesn't do that for a hot second. So those are the types of symptoms that you're going to get. If a patient has OH or orthostatic hypotension, the biggest thing to remember is fall risk precautions. Fall risk, fall risk, fall risk. You need to do slow position changes, slow ambulation, just to prevent that drop in blood pressure and potential fainting that comes with that. Awesome. Then's cardiac. I don't even remember how I organized this. Here are a bunch of the terms for the cardiac system. Again, it's not really the best use of time for me to go through term by term, but just make sure you have a general understanding of these. Something like Quizlet, flashcards would be good to make sure you understand these before the exam. Same goes for these equations, understanding cardiac output, which is the heart rate times the stroke volume, and also your blood pressure, which is cardiac output times systemic vascular resistance. Just knowing those equations, again, flashcards would be a good way to memorize those as well. Heart failure. Heart failure has a lot of misconceptions around it because your everyday Joe who isn't in healthcare thinks heart failure is an immediate death sentence. If your heart fails, you die. Like, you can't live without your heart working, which heart failure can be fatal. It can progress to that spot, but a diagnosis of heart failure does not literally mean that your heart stopped working. It just means that your heart cannot keep up with the body's demands anymore. So there's an insufficient output of blood, of oxygenated blood to the body. Um, in response to this decreased output by the heart, your body activates your natriuretic peptide hormones. BNP is the specific one that's released by cardiac cells. So the higher the BNP, the worse the heart failure. BNP is that key kind of lab value to tell you how the heart failure is. The higher it is, the worse the heart failure. Um, in response to that decreased cardiac output, the heart sometimes tries to adapt by getting bigger to maybe squeeze more effectively, but often that hypertrophy and that largening of the heart really just it doesn't help, and it does result in a lower ejection fraction, which is the term for the percent of blood pumped out of that left ventricle with each beat. These are going to be super, super important to understand looking at right versus left-sided heart failure. And I know you guys have a lecture tomorrow before the exam. Forgive me, I don't know what comes last in this unit, so I'm not sure if you've covered this quite yet or not. But this is super, super important to understand what right-sided heart failure looks like versus left-sided heart failure. When you think right-sided heart failure, you need to think the rest of the body. You need to think systemically. I put this diagram of the heart up on there because you can see, if you look at where it talks about, oh, I have this, the right atrium and the right ventricle. Through those inferior and superior vena cavas is where that right atrium takes in blood from the body. Takes it through the body, from the body, right ventricle, into the lungs to get oxygenated. So if that right side of your heart isn't pumping effectively anymore, the backup of blood is going to be out that superior vena cava and the inferior one. So your backup is going to be systemically with right-sided heart failure. And that backup of blood that's just waiting to get through the heart is going to cause things like hepatomegaly and splenomegaly, which is the enlarging of your liver and spleen. Ascites, which is fluid accumulation in your abdomen. That's that super like round and distended abdominal appearance. Vein distension, because again, your veins are filling up with backed up fluid. GI symptoms, peripheral edema, so excessive swelling, and weight gain. Left-sided heart failure, then, you're going to look at symptoms that are more specific to the lungs and not so much systemic. Because again, if you look at the diagram here, your left atrium receives blood from the lungs, not from your systemic circulation. And then it goes into the left ventricle and then out to the body. So if your left side of the heart is not pumping effectively and cannot do its job effectively, that backup of blood is now in the lungs. So a lot of your symptoms are going to come from that. Additionally, if you can't pump that left side effectively, the blood that you push out through the aorta to the rest of the body might not be sufficient either. And that's why you see some symptoms on there like weakness and fatigue. Just because, again, that cardiac output from your left ventricle is significantly decreased. With left-sided heart failure, those manifestations, again, are related to the lung. So left lung, LL. You're going to see orthopnea, so difficulty breathing in certain positions, like laying on your back. Dyspnea, cough. You can have wheezing and crackles from fluid buildup in the lungs. Cyanosis, low O2 saturation, and fatigue and weakness from that impaired left ventricular output. For heart failure, regardless of what side, you're going to educate your patient on a low sodium diet. You're going to help them with smoking reduction or cessation, lifestyle changes. And as the nurse, it's super important that you monitor their daily fasting weight at the very same time each day. That daily fasting weight is the best indicator of fluid retention and how their heart's doing, kind of circulating that blood throughout the body. You're going to monitor I's and O's and monitor labs closely as well. Speaking of labs, these are the ones that you need to know. You have ejection fraction, which is determined by an echo. Ideal is going to be 55 to 65, but you're going to see, maybe in the 40s, 30s, or lower in your heart failure patients. Their ejection fraction can actually be within the normal range, and they can still have heart failure. There's a bunch of different types of heart failure that can preserve your ejection fraction or not. but just know that range. BNP needs to be less than 100. Above that is an indicator for heart failure. And BNP is that key lab used to diagnose and monitor the severity of heart failure. Again, as that increases, the heart failure is worsening. Total cholesterol, potassium, the range there is 3.5 to 5.0. Serum digoxin, we'll talk about digoxin, the medication, in a bit, but that needs to be 0.8 to 2.0. And CK, creatinine kinase, needs to be 0.7 to 1.4. So again, flashcards are going to be your best way to memorize these. Perfect. Which of the following clinical manifestations would be expected from a patient who has right-sided heart failure? Awesome. Perfect. Edema, vein distension, and weight gain. Those systemic manifestations. Good job. Which of the following is the best indicator of fluid volume retention in a patient with heart failure? Perfect. Yep. The other ones are super, super important, but the best indicator would be that daily fasting weight. All right. This, I would argue, is the chunk, maybe the most intimidating chunk of meds for this exam in specific. Those antihypertensives and like cardiac glycosides can be super intimidating because they all have the same desired effect oftentimes. But I think I have perfect. Okay. Key notes that are applicable across the board for these medications. Like if you had to pick literally 4 things to know about every medication, this is what you should know. Um, Before you administer an antihypertensive, you will always, always, always need to assess their blood pressure. It doesn't matter if their blood pressure, is always high. You need to check it because if it's low or it's normal and you give an antihypertensive, you do not want to be responsible for that severe hypotension that can follow. With these medications, it is always important to monitor potassium and knowing which drugs are responsible for high or low potassium levels. You need to check for drug and herbal reaction interactions because there are some kind of sensitivities and herbal interactions that can occur with these medications. And always prepare for an increased fall risk related to antihypertensives. And that goes back to what I was talking about with OH. Just because these patients who are on antihypertensives are at an increased risk for low blood pressure and OH, which can increase their fall risk. So we'll start with the 3 diuretics that we need to know. The first one is the thiazide diuretic. It's hydrochlorothiazide, and it's shortened to HCTZ. It was my favorite one to say when I took this class. It was just fun. But hydrochlorothiazide is a first-line drug for hypertension and heart failure. The adverse effects are potassium loss, so it is a potassium wasting diuretic, and hypotension. And that's honestly one of the main adverse effects for all the antihypertensive drugs, because if they work too well or their dosing is too high, you're going to produce the opposite effect, which would be low blood pressure. For hydrochlorothiazide, there is a contraindication for a sulfonamide allergy. So that's an allergy that you will need to check and verify before administering hydrochlorothiazide. Spironolactone is a potassium-sparing diuretic. So it's not going to get rid of potassium. It's going to maintain it in the body, which means that there is an increased risk for hyperkalemia. Like the other, it is used for hypertension and heart failure. And because it causes that elevated potassium level, it's usually given with a potassium wasting or losing diuretic like furosemide, which is on the next slide. There is a black box warning for spironolactone, and there is an increased risk for tumors. So just kind of knowing that, keeping that in the back of your mind. I'm sure this is on a slide coming up, but if they're on a medication like spironolactone that causes high potassium, you need to educate them to avoid salt substitutes. And that sounds weird because we're talking about salt and that's sodium and not potassium. But salt substitutes are oftentimes heavy in potassium. So they can think they're doing themselves a favor by, limiting their sodium intake with these salt substitutes. But instead, they're giving themselves excess potassium, worsening this hyperkalemia that spironolactone can already be causing, if that makes sense. Furosemide, this is probably the most common diuretic you see in practice. It's called Lasix. I'm sure you've all given it in adult one already or seen it given. It is a loop diuretic that's primarily used for heart failure. It causes excess and immediate urination if it's given IV. And it is potassium wasting pretty heavily. Um, because of that, it's often taken with spironolactone since it's potassium sparing or with a potassium supplement. I would say in 90% of the cases that I've worked with, if a patient's on furosemide, repeatedly, they're also taking potassium supplements, which are those huge pills that usually come in a dosage of like 20 MEQ, I think is the most common dosage. But again, we're really, really considering that potassium balance here. Um, there is an adverse effect for ototoxicity as well, so ringing in the ears or just ear damage. And they are also contraindicated if an allergy to sulfonamides is present. If IV, we push it over 1 to 2 minutes or longer to avoid those ototoxic side effects. And again, with IV, that rapid diuresis will begin within the first 5 minutes. So if they're a fall risk, it's super important that you have a urinal or a commode or something right by the bed because they're going to need to be peeing like that. And, you want to consider if they're a high fall risk and the toilet's 20 steps away, they're going to try to get up to go. So you need to really keep in mind that need to go combined with their fall risk. Um, if taken with digoxin, which is the cardiac glycoside we'll talk about in a minute, there is a higher risk for digoxin toxicity. That's just an important thing to keep in mind if you see furosemide and digoxin together. So that was the three diuretics. So which of these diuretics puts a patient at risk for hyperkalemia or high potassium? Yeah. Spironolactone. A and C are going to be potassium wasting or putting the patient at risk for hypokalemia. Okay, I guess that was the only diuretic question I had. Um, so these are your other antihypertensives that are not explicitly diuretics. The first class here are your ACE inhibitors. The name clue is that they end in pril. The prototype here is captopril. In practice, I feel like I see lisinopril a lot. But these work by blocking that angiotensin converting enzyme, which in that renin-angiotensin aldosterone system kind of cascade is responsible for that increase in blood pressure towards the end. That's what allows for the release of aldosterone. So again, it'll block that enzyme to bring down blood pressure. Your adverse effects here are neutropenia, agranulocytosis, angioedema, dysgeusia, which is like altered taste, dry cough, renal like signs and symptoms, hyperkalemia, and first dose orthostatic hypotension. And that's exactly what it sounds. When you take a ACE or an antihypertensive like an ACE inhibitor, your body might kind of drastically respond with that very first dose. And that's how you can induce something like OH. There is a black box warning for pregnancy. ACE inhibitors are just not safe to take if you're pregnant. That's the key takeaway there. And again, because ACE inhibitors have an increased risk for high potassium, you need to teach patients to avoid those salt substitutes. Your ARBs, these are angiotensin 2 receptor blockers. And then, like the name clue there is that they end in sartan. The prototype is losartan. And again, when we're looking at that RAAS system or cascade, this one works specifically by inhibiting angiotensin 2. So this is just a different step in that cascade compared to ACE inhibitors. Adverse effects here are hyperkalemia again, so high potassium, angioedema, and then hypotension and cough. And it's just important to keep in mind that they reach their maximum effect in 3 to 6 weeks. So if a patient is in a hypertensive crisis or urgency, this is not going to be your medication of choice to fix it today and now. This is, for your chronic high blood pressure patients, maybe it's a little bit high, but we're not an immediate concern for organ damage or stroke. This could be a medication that we would consider putting them on because we do know it's going to take a little bit longer to have an effect. Beta blockers. These are my favorite class. I don't know why. I felt like they were always the easiest to remember. They end in OLOL, that LOL ending there. The prototype here is propanolol. You'll see that one a lot moving forward in nursing. Beta blockers block receptors to induce decreased heart rate, decreased cardiac contractility, and decreased blood pressure. They're used primarily for hypertension and heart failure. And the adverse effects are bradycardia, so slow heart rate, and bronchospasm, which we talked a lot about in the last unit. A good way to remember those adverse effects is it's all the B's. Beta blockers, bradycardia, bronchospasm. Black box warning here, you don't want to stop abruptly if the patient has coronary artery disease because there is an increased risk for heart attack and angina. So it's kind of a unique one, but definitely something to keep in mind. Nursing interventions, this is super important. You need to take their apical pulse and their blood pressure before giving. And general parameters are if that apical pulse is less than 50 to 60 beats per minute, or their blood pressure systolic is less than 90 to 100, you need to notify the provider and hold that medication. Because again, you don't want to cause their heart to drop under 50 or that systolic to drop under 90. If a beta blocker is given IV, it's a high alert med. So you need to take into account all those precautions that we learned about in the past, the tuner sign off, the special protocols, etc. Just because there's a higher risk for patient harm. Calcium channel blockers, the main one here is amlodipine. I didn't put it on there, I guess, but the name clue is like dipine, because another one is nimodipine. Used for hypertension. The thing with calcium channel blockers is that they're not ideal for heart failure because it does reduce cardiac contractility. So with heart failure, your heart's already having a hard time pumping effectively, and a calcium channel blocker is going to inhibit that even more, worsening cardiac output. So calcium channel blockers are better for your patients who just have hypertension without heart failure. Because calcium is required for muscular contraction. So if you block that calcium, you're going to see weaker contraction and weaker blood vessel constriction, which allows for your blood vessels to relax and therefore lower your blood pressure. Cardiac glycoside. This is digoxin. Digoxin works by improving cardiac contractility, and it's primarily used for heart failure specifically. There's a very fun song on the internet. I don't know, you guys have probably seen it on TikTok and stuff, about digoxin. Great memory tool to help you. If you look up digoxin nursing song, it'll come up right away. Just talks about the uses for digoxin and stuff. It's fun. It's given IV push pretty slowly. The typical is over 5 minutes. And digoxin has a very narrow therapeutic range of about 0.8 to 2.0. Above that 2.0 is when you get to a risk for toxicity. So people on digoxin more long-term are gonna have those lab values drawn pretty frequently to make sure that they stay within that narrow therapeutic range. For nursing interventions, we don't give digoxin with antacids or dairy. It's another high alert med, and we do need to monitor potassium. That's a fun pattern throughout all of these. You're going to assess the apical pulse for 1 full minute prior to administration. And if that apical pulse is under 60 beats per minute, you're going to hold that medication. Dig toxicity is a real thing, and it's super important to monitor because, again, there is a narrow therapeutic range. So digoxin is only going to have its desired effects within that specific range. The risk for digoxin toxicity is increased with hypokalemia or low potassium. So if your patient has low potassium or they're on a potassium wasting drug like furosemide, you need to monitor their DIG levels and make sure that they're not experiencing DIG toxicity. Those early signs and symptoms of toxicity are going to be anorexia, nausea, vomiting, so think GI. And the late signs and symptoms are going to be vision changes, weakness, confusion, and arrhythmias. So it can get pretty serious pretty quickly. And the antidote there is digoxin immune fab. So I would, whenever there's an antidote in all of nursing school, you need to know the antidote. Alrighty. Which of the following statements from a fellow nurse needs correction in regards to the administration of propranolol, the beta blocker? This one might be a little bit trickier. You guys are hesitant. Yeah, perfect. Yep. So that's B. The reasoning there is that you need to not only take it, but you need to assess it. And you also need to assess that apical pulse. So it's not just blood pressure, it needs to be blood pressure and apical pulse. And you need to compare that with the administration parameters to make sure that it's still safe to give after um, the fact. True or false, patients taking lisinopril and spironolactone should avoid salt substitutes in their diets. Yay. Yes. Again, yep. And that's what I said a few times. So, yep, that's true. Which of the following serum digoxin levels requires follow-up? Yep. That therapeutic range is there at zero point 0.8 to 2.0, so 2.6 is going to be elevated and requiring follow-up. Perfect. If you guys want to respond, what are some signs and symptoms you would expect to see in a patient who has that DIG level of 2.6? You can send them privately or to everyone either way. If I just get two people, that would be my goal. Yes. Yes. Anorexia, nausea, and vomiting, those are those early signs and symptoms of DIG toxicity. Perfect. And someone messaged me arrhythmias. Yep, arrhythmias are a late sign of DIG toxicity. Good job, guys. Put those on there for you. All right, that is everything with heart and hypertension. And I know that it's a lot and it's heavy content, and I kind of went through it quickly. So again, you have a week before your exam. Take time, break it down class by class, and if you need me, I'm here. And so is your professor. The last kind of category on this exam is going to be stroke and TIA content. The great thing about it is that it's pretty, I don't want to say surface level, but in a way it is. It's just kind of making sure you understand what different types of strokes and TIAs look like and some most common medications used. So there's not an insane amount of information here, which is pretty good. Um, Here are just some more terms. Again, we only have about 10 minutes left, so I don't want to spend too much time there, but just understanding these would be important for you to do. A transient ischemic attack is a warning sign for an impending stroke. With a TIA, there was a disturbance in blood flow, just like there is with a stroke, but it was brief or temporary, and the damage is reversible. So all of those signs and symptoms do resolve within 24 hours. I said similar to angina, but for the brain. Angina is when there's temporary disturbances in coronary blood flow causing heart or cardiac issues. TIA then would be that disturbance in cerebral blood flow producing stroke-like symptoms. So you can see things like changes in speech, vision, you can have dizziness, one-sided weakness, etc. To prevent further TIAs or strokes, these patients would likely be put on aspirin or clopidogrel. Strokes are the sudden impairment of one or more blood vessels which supply the brain, um, and oftentimes they come with sudden focal neurological symptoms, just like the ones we talked about, weakness, especially one-sided, slurring speech, confusion, etc. With a stroke versus a TIA, they are going to last for more than 24 hours. These are not quickly resolved symptoms, and they could be ischemic or hemorrhagic, which we'll talk more about in a second. The risk factors, same list that we've kind of seen before with your modifiable and non-modifiable risk factors. For modifiable, you have hyperlipidemia, hypertension, diabetes, and those lifestyle things. So definitely knowing which things are causing an increased risk for stroke. This is just the BFAST assessment. It's important for anyone to know, even if you're not in healthcare, because anyone can identify a stroke. So these are just some of those common signs and symptoms of a stroke. Often you can have people, I was in ED triage a few weeks ago, and there was a potential stroke patient coming in. And the first thing we did is say, smile for us and see if that smile's even. We said, hold out your arms. Are they even? Can you talk? And then, we're just quickly going through these things to make sure that they either are or are not exhibiting those signs and symptoms of a stroke. Ischemic strokes are responsible for the large majority of strokes, up to 87%. So this is when usually there's like a atherosclerotic plaque, so that cholesterol buildup, or maybe a clot, like from AFib or something, gets into one of your cerebral arteries and blocks blood and oxygen delivery to brain tissue, causing, that specific area to, I guess, just lose oxygenation and blood supply. So your treatment for ischemic strokes are IV thrombolytic therapy, which is TPA, and then you can do aspirin and antiplatelets to prevent repeat strokes. Hemorrhagic strokes, then, these are not caused by the blockage of a vessel like an ischemic stroke is, but rather a rupture of a cerebral artery where blood then kind of bleeds out into brain tissue. These are less common, but also more fatal than your ischemic strokes. With these, they manifest the same way as ischemic strokes, but they're typically a faster onset, and nausea and vomiting can come with them. And also, patients can complain of the worst headache of their entire life. So, those are three more unique symptoms to hemorrhagic stroke specifically. An aneurysmal subarachnoid hemorrhage, or an SAH, is when the bleeding is occurring in the subarachnoid space. So that's just a specific type of hemorrhagic stroke. The treatment here is a calcium channel blocker called nimodipine. It's neuroprotective and it'll prevent vasospasm of those vessels that have ruptured, which we'll talk about more in a moment here. The biggest medication when we're talking about ischemic strokes. So we're thinking there's a clot, there's a plaque, there's a blocked vessel in your brain, is TPA, or tissue plasminogen activator. It is a fibrinolytic that dissolves a clot, essentially. There are a lot of parameters, contraindications, administration, things to keep in mind here. You must start the medication within 3 to 4.5 hours from the onset of signs and symptoms. Additionally, those signs and symptoms need to not be getting better, because if they're getting better, this could be a TIA and not an ischemic stroke. So typically you need to confirm an ischemic stroke with imaging. If a patient is on current anticoagulant therapy, if they have a history of internal bleeding, or their blood pressure is above 185 over 110, they cannot take TPA, because TPA comes with a very, very, very high risk of causing bleeding. And you don't want to try to correct a problem by causing an even bigger problem. So while TPA is super, super effective in dissolving a clot and helping, reduce the impact of a ischemic stroke, the risk for bleeding is so huge that you really, really need to consider these contraindications. If a person too, say they got a stroke, or the last time you saw them was yesterday at lunch when you went to visit them, maybe this is your grandparent, and you come the next day at lunchtime and they're acting like they're having a stroke, they're not a candidate for TPA because their last known well, that last time that you laid eyes on them without their symptoms was 24 hours ago. And you need to know to be able to give TPA that those symptoms started less than basically 4.5 hours ago. That's the term last known well. What's the last time that they were normal, essentially? Administration of TPA, it needs to be given over about 1 hour. It is a very high alert med. The dosage is typically zero point 0.9 milligrams per kilogram, so it's important to have an accurate patient weight. You do some cardiac monitoring for a patient on TPA. And TPA, again, because it is such a high risk medication, it does require consent forms. TPA, again, increases your risk for bleeding severely. So if bleeding develops, you stop the medication, and the antidote is aminocaproic acid. Nimodipine, this is that medication that acts as a neuroprotectant that prevents vasospasm, or like the spasming of your cerebral vessels after a subarachnoid hemorrhage. Its main adverse effect here is orthostatic hypotension. And because it can induce hypotension, your main contraindication is if they're already hypotensive with a systolic blood pressure of 90 or lower. Nursing implications, no grapefruit. That's pretty common if all else fails. No grapefruit. 60 milligrams every 4 hours for 21 days after the subarachnoid hemorrhage is pretty common dosing. And typically it needs to be started within 96 hours after that subarachnoid hemorrhage to be the most effective. This is the last slide, guys, and then a few more practice questions. Aspirin is an antiplatelet medication that decreases the risk of vascular clotting. We've talked about aspirin before when we talked about NSAIDs. The dose is anywhere between 81 to 325 milligrams a day, and that's just pretty dependent on the patient's need, looking at if we're preventing a stroke or treating one, if they've had them before or not. With aspirin, you want to educate your patient to report signs of bleeding and that to protect their stomach, they need to take it with food, just like we do, ibuprofen and these other NSAIDs. Clopidogrel then, its brand name is Plavix. It's an antiplatelet medication, just like aspirin. It has some more adverse effects like diarrhea, rash, those GI bleeds, as well as low neutrophils and platelets. So just kind of think what that would mean. Low neutrophils, maybe we're immunocompromised and we can't fight infection as well. And platelets being low, we're at a higher risk for bleeding and impaired clotting. With clopidogrel, there are many interactions with herbal products, specifically the 4Gs that are listed on there, which is why when you do any kind of medication reconciliation or education, or you're asking, your patient what their home meds are, you need to go ahead and specify, hey, you told me you take this med and this med and that med, but do you take any over-the-counter vitamins or supplements? I mean, green tea is on there. Like, that's a drink. So you need to be really specific because a lot of people wouldn't think to report supplements like ginger when they're giving you their home medications. But again, there are interactions there that you need to check for. Yay. Okay. What is the antidote for TPA? Yes. Aminocaproic acid, and that would be administered if the patient develops signs and symptoms of bleeding after TPA administration. Which medication works to dissolve clots? I just said this. Yeah, that's TPA. I have a lot of TPA questions if you can't tell. It's super important. Wink, wink. Which of the following are nursing considerations for the administration of TPA? This is a select all that apply. I just forgot to type it. This one's all of them. I literally copied and pasted the list from the slide. All of these things are nursing considerations or interventions implications that you need to keep in mind for the administration of TPA. Your patient is experiencing an ischemic stroke and could potentially receive TPA. Which of the following present as contraindications to receive TPA? Select all that apply. I'm sorry, I'm killing you with these. Select all that applies. Yeah, good job, guys. B, C, and E. Um, you're looking, yes, they're on anticoagulant therapy, being warfarin. That blood pressure is above that 180, 110 restriction that's set. And that last known well was outside of 3 to 4.5 hours ago. So good job. A, even though it's hypertension, it still falls in a level that's safe enough to give TPA. So you guys were right. Awesome. And that is everything that I have for you guys for this unit. I know it was a lot of information. Let me go ahead and stop recording.